Good afternoon, everyone. Now, after extensive talk of Dr. Thomas, who focused more on pathophysiology, and another thing is he was very short and precise. Probably I take the disclaimer that I may extend little bit more because my topic is on cyanotic heart diseases, and there are so many things to cover, so I could not think that what to cover, what to skip. So I tried my level best to make it as concise as possible, and as the most of the audience are from MBBS category and beginners of MCH, so I tried to make it little bit more basic thing related to congenital cyanotic heart disease. So whenever we are talking about congenital heart disease, it is a very extensive focus of studies. So it is not possible to remember everything. So all students just remember THE, the. So you are the king of cardiothoracic surgery. So remember THE, and you will cover most of the congenital heart diseases. T, remember 5 T's. First, tetralogy of Fallot, then transposition of great arteries, truncus arteriosus, TAPVC, and tricuspid atresia. So if you remember 5 T's, that constitutes most of the congenital cyanotic heart disease. Then comes H, which is hypoplastic left heart syndrome, which is a left-sided lesion. And then come to the E. E is Epstein's anomaly. If you remember these many diseases, probably you will cover 90% of the congenital cyanotic heart diseases. Let us come to the basics of congenital cyanotic heart disease. I'll take a little bit more time. I'll discuss little bit of basics and the basics of individual diseases. So what is cyanosis? Cyanosis is the bluish discoloration of the mucous membrane and skin, usually noticed in the peripheries or in the undersurface of the tongue, lips, in the mucous membrane. So there are 3 types of cyanosis: peripheral cyanosis, central cyanosis, and differential cyanosis. So coming to cyanosis, when we say cyanosis, when there is increased level of reduced hemoglobin to more than 5 gram per deciliter, it can be called as cyanosis. Second thing is when there is increased concentration of abnormal hemoglobins like methemoglobinemia or sulfhemoglobinemia, that can cause cyanosis. Now, what is the incidence? The incidence of congenital heart disease as such is 8 to 10 per 1,000 live births. Out of that, 25% constitutes congenital cyanotic heart disease. And out of all congenital cyanotic heart disease, the most common congenital heart diseases are tetralogy of Fallot and transposition of great arteries. Tetralogy of Fallot constitutes almost 8 to 10% of congenital cyanotic congenital heart diseases, and TGA constitutes somewhere around 5 to 7% of the congenital heart disease. So in your practice, most of the time, most of the places, you will find mostly these 2 lesions which comes across in common practice. And most of them, they present at early stage of life, at birth or immediately after birth, and most of them are diagnosed before 1 year of age, and treatment should be given as early as possible. Now coming to cyanotic heart diseases, you see it can be duct independent mixing, duct dependent lesions, and duct dependent systemic blood flow. So in this category where it is not related to duct dependent lesion, it is purely because of mixing, are truncus arteriosus, transposition of great arteries, and TAPVCs. When it comes to duct dependent lesion, because here in this scenario, the child survives depending on the duct flow. So those type of diseases are tricuspid atresia, pulmonary atresia, tetralogy of Fallot with severe PS, Epstein's anomaly. Coming to duct dependent systemic blood flow are hypoplastic left heart syndrome, interrupted aortic arch, and TAPVC with obstruction. Now, what are the causes of cyanosis? It can be because of reduced pulmonary blood flow or because of intracardiac mixing. So reduced pulmonary blood flow can be because of tricuspid atresia, pulmonary atresia, and critical PS in tetralogy of Fallot. Intracardiac mixing can be because of TAPVC, double inlet, left ventricle, and so on. So what happens if you are not treating these patients early? If you are not treating the untreated patients, the untreated patients develops poor or stunted growth, polycythemia, severe cyanosis and clubbing. Because of polycythemia, the hyperviscosity syndrome happens, and hyperviscosity causes brain abscess and multiple thromboembolic events. So how do you diagnose these patients? Of course, it is a cyanotic heart disease, so cyanosis definitely will be there. That is the first criteria to see whether there is cyanosis or not. You can see the cyanosis in the nail beds, in the palm, sole, all mucous membrane. Then they can present with dyspnea, easy fatigability, failure to thrive, hypoxic or TET spells. I'm not going to details of this because these are all medical management areas which I'll touch later. Then syncopal attack, chest pain, congestive heart failure at a later stage. How you will diagnose? Once you will get some conclusion from the symptoms, then you have to auscultate. That is, you have to find out the murmur. Usually tetralogy of Fallot murmur will be ejection systolic murmur of pulmonary stenosis, and you will find in the left upper parasternal area. If it is a case of pulmonary atresia, you will find PDA flow murmurs, which will be a continuous murmur. Coming to truncus arteriosus, I'll come in detail later. Truncus arteriosus is a trunk which arises from the heart instead of two separate great vessels. So here mostly we find there will be some truncal valve regurgitation that causes late diastolic regurgitant murmur at the lower left sternal border. And as it is a single vessel arising from the heart, second heart sound will be single. In case of TGA, they will present with cyanosis and severe metabolic acidosis and have systolic murmur. Coming to ECG, you will find in tetralogy of Fallot there will be right ventricular hypertrophy, TAPVC, TGA, all these cases you will find right ventricular hypertrophy with right axis deviation. In truncus arteriosus you will find biventricular hypertrophy. In tricuspid atresia, pulmonary atresia, mostly right-sided lesion you will find left ventricular hypertrophy. And in Epstein's anomaly you will get delta waves and right bundle branch block. Then we do X-rays. In X-rays, what you found? These are the four very interesting terms which is used mostly in entrance examination. Also they ask this. So first one is egg on the side appearance. In which condition you will get egg on the side appearance? Egg on the side appearance happens in transposition of great arteries. And why is that? Because the heart shape is globular in this case, and at the same time the superior mediastinum there will be hyperlucency or hyperlucency of the lungs with absence of thymus or thymic hypoplasia. So this part becomes narrow. In this case it is not there because it is wide because of thymus, but mostly the thymus thymic area will be narrow because of hypoplasia of the thymus, and the great vessels will look like a small string. So that is the reason it is called egg on the string. Then coming to the tetralogy of Fallot, in tetralogy of Fallot, there will be right ventricular hypertrophy. Because of right ventricular hypertrophy, the apex will be shifted and lifted up. And at the same time, there will be concavity of the pulmonary bay. So because of concavity of the pulmonary bay and right ventricular hypertrophy lifting the apex up, it causes boot-shaped heart. You must have heard about boot-shaped heart. Coming to TAPVC, total anomalous pulmonary venous connection, here the shape is called snowman heart or cottage lobe appearance of the heart. What is that? That is because in TAPVC there will be, in supracardiac TAPVC especially, there will be ascending vertical vein which will be dilated because all the pulmonary venous blood through the vertical vein goes to innominate vein, then comes to the SVC. So there will be dilated SVC, there will be dilated vertical vein. That gives the appearance of a globular structure which is the head of the snowman, and the dilated heart itself gives the body of the snowman, so it gives the appearance of snowman. So it is called snowman appearance on X-ray. Then coming to the other category, which is called box-shaped heart, that you will get in Epstein's anomaly. In Epstein's anomaly, what happens? There will be hugely dilated right atrium, and there will be dilated RVOT. So that gives a box-like appearance, which is called box-shaped heart. Coming to the individual diseases, now I'll focus mostly on tetralogy of Fallot and TGA. As I said earlier, these two are the common subset of cyanotic heart diseases we come across in day-to-day practice. So what is tetralogy of Fallot? Tetralogy of Fallot constitutes 4 components. First is ventricular septal defect, then pulmonary stenosis. Pulmonary stenosis can be supravalvular, valvular, or infundibular, and then right ventricular hypertrophy, and the 4th one is overriding of the aorta towards the right side. So these 4 constitutes tetralogy of Fallot. So as I said earlier, tetralogy of Fallot constitutes 7 to 10% of the congenital heart diseases. Male, female are equally affected, and 15% of cases they are associated with any of these syndromes. So how to make a decision when to treat these patients? So this is a very useful thing to express. If the patient is having mild cyanosis and there is no major comorbidities, so if there is mild cyanosis, no major comorbidities, just start some beta blocker and wait for 3 to 6 months. Usually 3 to 6 months in Western countries, they are operating at the age of 3 months. But in India, in most of the centers, we prefer to operate between 6 months to 1 year of age. There are certain centers who are operating at the age of 3 months as well. If the patient is having severe cyanosis, then go to the weight. If the weight is 3 kilos, and Nakata index is more than 100 ml per meter square. What is Nakata index? Nakata index is the cross-sectional area of right pulmonary artery and left pulmonary artery divided by body surface area. So that gives you some indication that if the Nakata index is more than 100 ml per meter square and the weight is 3 kilos or more than 3 kilos, go for neonatal surgery in case of severe cyanosis. If the patient is less than 3 kg or premature child, Nakata index less than 100 ml per meter square, then stage the procedure. So what is staging that and what are the stages that I'll describe later. So you can stage. You can do RVOT stent, you can do PDA stent, you can do systemic to pulmonary artery shunt, and then subsequently you can go for second stage, that is corrective surgery. If there is mild cyanosis, but there will be comorbidities like any abnormal coronary crossing the RVOT, or if the weight is less, if the patient is having associated abnormalities like tetralogy with AV canal defect, so in those cases, stage it first with PDA stent or RVOT stent or BT shunt, and then go for complete repair. Now, what type of repair we do? If the patient is having mild pulmonary stenosis, where you will find a ventricular septal defect, right ventricular hypertrophy, right ventricular muscle bundle, and there is valvular stenosis, and the G score of the pulmonary valve annulus is less than -1. Always remember 0 is normal, more than 0 is more than acceptable. So you can see if the G score is less than -1, you can do transatrial transpulmonary approach, close the ventricular septal defect, remove the RVOT muscle bundle, and then some valvotomy or supravalvular tethering release you can do. So it is a valve sparing repair. If the patient is having tetralogy with moderate pulmonary stenosis, in that case there will be valvular as well as supravalvular stenosis. In these cases, the G score is -1 to -3. Go for transatrial transpulmonary plus minus ventriculotomy. Sometimes many surgeons at many centers, they do ventriculotomy to do complete valvotomy as well as infundibular resection. And in this case, you can spare the valve with a infundibular patch, which where you open the RVOT, there you can put a patch. Coming to the severe grade of RVOT obstruction, where there is multi-level obstruction and G-score is less than -3, there we can go for transannular patch with or without monocus valve. Again, it is a variation. Few surgeons prefer to put a valve, few surgeons don't prefer the valve, they just leave it with transannular patch. Coming to systemic shunt, which is a palliative procedure, as I said, in the first stage, suppose the patient is not suitable for complete correction, we do palliative shunt. So in palliative shunt, there are multiple types of shunt, classical shunt, then modified shunt. So classical BT shunt is Waterston shunt, Potts shunt. So Potts shunt is anastomosis of ascending aorta with the right pulmonary artery. Waterston shunt is ascending aorta to right pulmonary artery. Potts shunt is descending aorta to left pulmonary artery. Nowadays, very rarely people are doing that. So mostly used shunt is modified Blalock Taussig shunt, which is done between there is a prosthetic graft which is used to put the shunt from subclavian artery to the pulmonary artery, either on the right side or on the left side. Then coming to the corrective surgery of tetralogy of Fallot, what we do? We close the VSD. You see, this is the position, this white patch we use, which is a Gore-Tex patch. We close the VSD. Then we do infundibular resection. The subvalvular area where there is obstruction, we cut the muscles and remove that obstruction. Then we do pulmonary valvotomy. If there will be pulmonary valve commissural fusion and supravalvular tethering. So we release the supravalvular tethering and do commissurotomy. So that comes under pulmonary valvotomy. If you are putting a transannular patch, it can be with valve or without valve. And creation of a valve by again there are multiple techniques: monocus valve, bicuspid valve. So that can be used. And later, when the patient presents with free PR with RV dilatation and arrhythmias and all these things at an adult stage, post tetralogy repair, we go for pulmonary valve replacement. This is one of the recent paper published in International Heart Journal in March 2025, 50 years follow-up, where they said the tetralogy repair, the 50-year survival is around 71% and in-hospital survival is 84%. And most of the patients went for re-intervention, almost 40%. And common causes are arrhythmias, supraventricular arrhythmias. Coming to transposition of great arteries, as I said, incidence is 5 to 7% of the congenital heart disease. So what happens in this? Normally the right ventricle gives rise to pulmonary artery, and the left ventricle gives rise to aorta, which is called ventriculo-arterial concordance. In this case, there will be ventriculo-arterial discordance. That means the right ventricle will give rise to aorta and left ventricle will give rise to pulmonary artery. So there are two types of TGAs, DTGA and corrected TGA. So the difference is here it is physiologically corrected because there will be atrioventricular discordance, ventriculo-arterial discordance. So ultimately, the physiologically it is corrected. So that is the reason it is called corrected transposition of great arteries. And in the treatment, it is very important to assess the coronary anomaly in case of TGA because based on that, your mortality, morbidity, and prognosis depends. So in TGA, you will find almost 33% coronary abnormalities are associated with transposition of great arteries. There is a Leiden convention for coding the coronary artery system to know it describes the origin and branching of the coronary arteries. How it is described, the clinician has to stand on the non-facing sinus of the aorta and facing towards the pulmonary valve. The right-sided sinus is called sinus 1 and the left-sided sinus is called sinus 2. So based on that, the cardiologist describes which sinus, which coronary artery is arising. So this is the normal one. You can see sinus 1 giving rise to, here the person is standing and facing towards the pulmonary valve. So right side is this one, left side is this one. So right is giving rise to right coronary artery, left is giving rise to LAD and circumflex, which is normal. In 65% of patients, you will find this, but most common variant in case of TGA, where the sinus 1 gives rise to right coronary artery as well as circumflex artery. So what are the surgical steps for correction of transposition of great arteries? So the first stage is division of the great arteries. So divide the aorta, divide the pulmonary artery, then harvest the coronary button. So coronary artery which is arising from the great vessel which is arising from the right ventricle. So harvest the right coronary artery, harvest the left coronary artery, then reimplantation of the coronary artery to the neo aorta. So place this here, which is going to be neo aorta. Now this pulmonary artery is arising from left ventricle. So here you have to replace it. After harvesting from here, you have to anastomose to the neo aorta. Then do the Lecomte maneuver, which is a maneuver just to change the position of the great vessels, bring the aorta down and bring the pulmonary artery up so that there will be less kinking, less traction, and free laminar flow on both the great vessels. Then neo aorta, distal neo aorta, the place where you divided, this is distal part. So distal part is anastomosed to the neo aorta. Then neo-pulmonary artery reconstruction. The place where you remove this coronary button, that place there is a deficient area. So you have to put pericardial patch, reconstruct that area, and then neo-pulmonary artery to distal pulmonary artery anastomosis. That completes your arterial switch operation. If there is a VSD, you have to close the VSD along with this. So what are the complications in these cases? So complications are early complications. In the post-operative period, you will find arrhythmias. If coronary artery is not placed properly, there is any kinking, tortuosity, twisting that can cause multiple arrhythmias. Then low cardiac output syndrome, baffle, leak or obstruction, and right ventricular failure. All these things are early complications of repair of transposition, that is arterial switch operation. Late complications are, most common is aortic root dilatation, coronary problems, valve related problems, LVOT obstruction, and other problems which is unrelated are ADHD and developmental delay. So this is an article from Royal Children, Melbourne by Christian Brizard and all. They published this in 2022 March in JTCVS, one of the journal in cardiothoracic surgery, where they studied retrospectively on 844 patients. The follow-up was 15 years, median follow-up, and the longest follow-up was 25 years. The early mortality was 3.3%. Overall survival was 95%. And freedom from reoperation was at 25 years was 77%. So why I quoted this? Because this gives a idea that transposition of great arteries is a very good subset to treat and cure them. Coming to the third subset, which is very common in India, is total anomalous pulmonary venous connection. So what happens in this? The pulmonary veins connect to the right-sided structure, right atrium or superior vena cava or innominate vein rather than on the left side. So all the pulmonary veins, instead of opening to the LA, they open to the RA, either via vertical vein or directly. So these are the various types of TAPVCs. Supracardiac, which is the most common variety, 45 to 50%. Cardiac variety, infracardiac variety, and mixed variety. In supracardiac variety, you see the common chamber which is behind the heart. All the pulmonary veins are joining there to the common chamber, and from common chamber, vertical vein is ascending, joining the innominate vein, and through that, the blood flow is coming to the right side of the heart. And the patient survives based on the atrial septal defect. Whatever blood comes, whatever blood flows through the ASD to the right side, that goes to the systemic circulation. So this is the supracardiac variety. In the cardiac variety, all the common chamber veins, the common vein joins to the coronary sinus. In the infracardiac variety, the descending vertical vein joins to the inferior vena cava or hepatic veins. And in the mixed variety, any of the subset can be mixed. Mostly cardiac plus supracardiac. So what do we do in this case? the basic principle is make the anastomosis, make a opening between the common chamber of the pulmonary vein to the left atrium. So immediate post-operative complications can be low cardiac output, pulmonary arterial hypertensive crisis, pulmonary venous obstruction, and arrhythmias. So post-operatively, it is a challenging subset to manage in the ICU. I'm sure Dr. Ganpati is going to discuss about this in detail. Coming to the truncus arteriosus, this is again another subset which is a rare subset, the single blood vessel which emerges from the heart instead of two separate blood vessels. You see, this is the normal heart, and here the common trunk is arising from the ventricle. There will be an associated VSD, and this common trunk gives rise to pulmonary artery. So as per Collett-Edward classification, which is commonly used classification for truncus arteriosus, the type 1 is this one where there is a common trunk and arising from the pulmonary artery trunk arising from the common trunk and then giving rise to left and right pulmonary artery. In type 2, there is no common trunk. The right and left pulmonary artery arises from the posterior aspect of the trunk. When it is arising from the lateral aspect of the trunk, that is type 3. And in type 4, neither it will arise laterally or as a trunk, common trunk. It is completely arising from somewhere else, that is called collateral. Usually it is not included in the classification because this subset is now considered as pulmonary atresia with VSD. There is another classification, I am not going into the detail of that. So usually the type A is where there is a VSD and type B is where there is without a VSD, which is a very rare subset. In most of the cases, you will find VSD. So again, type A is divided into 4 categories. So what do we do in case of truncus arteriosus? In truncus arteriosus, first step is open the aorta, divide the trunk, and then anastomose this part. Then open the RVOT just below the valve, close the ventricular septal defect, maintain the continuity of pulmonary artery to the right ventricle either directly or through a conduit. The conduit can be homographed, conduit can be bovine jugular vein, or you can directly connect to the RV posteriorly, and anteriorly you can augment with a patch. So this is the final look after truncus arteriosus repair. I am not going into the detail of this, it is not very common. Coming to tricuspid atresia, in tricuspid atresia you will find there will be no tricuspid valve, there will be hypoplastic right ventricle, and there will be with or without pulmonary stenosis. If there is a pulmonary stenosis, the lungs are protected, the single ventricle palliation can be done as a primary procedure. But if there is a free blood flow to the pulmonary artery, they may develop pulmonary vascular disease, which in which case you can do, in that case you cannot do single ventricle palliation. So we need to put a band to protect the pulmonary artery, and subsequently we can go on single ventricle line. So there are two ways to palliate these patients, BD Glenn and Fontan procedure. So BD Glenn is diverting the superior vena cava blood directly to the pulmonary artery, and in Fontan directing the inferior vena cava blood to the pulmonary artery. So you are bypassing this right ventricle. Coming to Epstein's anomaly, it is the displacement of septal and posterior leaflet towards the apex of the right ventricle. So what happens? That divides the right ventricle into two parts, true right ventricle and atrialized ventricle. So right ventricle becomes very small and non-functional, and there will be dilatation of the RVOT, and there will be severe tricuspid regurgitation. Coming to interrupted aortic arch, when there will be luminal discontinuity between the arch of aorta and descending aorta, that is interrupted aortic arch. As per this classification, there are 3 types of interrupted arch: type A, type B, type C. Type A, where there is complete disruption of the or discontinuity of the arch of aorta after the origin of the left subclavian artery, and the descending aorta arises, the descending aortic blood comes from the PDA. So PDA continues as descending aorta. That is type A. Type B, when the interruption is between the left common carotid and left subclavian, left common carotid and left subclavian. So this is type B. Type C, when there is innominate artery and left common carotid artery, there is a disruption or discontinuation between these two. The treatment is again luminal, maintaining the luminal continuity. Coming to hypoplastic left heart syndrome, it is a subset where there will be complete hypoplasia of the left side of the heart. It can be hypoplastic mitral valve, it can be hypoplastic left ventricle, it can be hypoplastic aortic valve, it can be hypoplastic ascending aorta, hypoplastic arch. So what do we do? Again, it is a single ventricle palliation. So what we do in the first stage, we do Norwood procedure. In Norwood procedure, what we do, we divide the pulmonary artery, maintain the continuity of the aorta and pulmonary artery, join it together and maintain the flow to the descending aorta. If there is any hypoplasia of the arch, you have to augment that also, and then put a shunt to the pulmonary artery. So the pulmonary artery flow will be purely through the shunt, and the systemic flow will come from the ventricle. And then in the next stage, you will do Glenn operation followed by Fontan operation. So take home message is congenital cyanotic heart diseases are treatable. The key is it should be diagnosed early and should be treated as early as possible. By treating early in their life, you can increase the lifespan of the patient and you can make their quality of life better. Thank you.
Any questions?
Dr. Swain, it is a very nice lecture. I think I thoroughly enjoyed the lecture. So maybe it may stimulate some of our younger generation to